So this is a case presentation which we are doing this time, where the student will be presenting a 70 years old patient presenting with dyspnea, and the examiners being Dr. Nagmani, professor from Jaydeva, and also Dr. Anupam Bhambani, professor of AIMS Patna. So once this case presentation is done, we'll have a short presentation by Dr. Mutaya, who is a specialist in cardiac electrophysiology, on the topic of this case. So welcome you all. We'll start with the case. Go ahead, Dr. Sudarshan.
Yes, ma'am. Thank you, ma'am. A 70 years old male patient named R. Chandar Rao, resident of Vizag, working as a watchman, belongs to low socioeconomic status, came with chief complaints of breathlessness and exertion for last 3 years, chest pain for last 3 years, giddiness for last 2 years. History of present illness. Patient was relatively asymptomatic 3 years ago. He started noticing the breathlessness and exertion, which was insidious in onset, gradual in progression, and occurring while walking to his workplace around 1 to 2 kilometers from his home and while going up 2 flights of stairs, which is NIHA class 2, which gradually progressed to breathlessness and doing the household activities like the dressing, undressing, taking the bath, and climbing the wall. Climbing 1 flight of stairs, NIHA class 3, over the course of last 1 year. No history of orthopnea, no history of PND, no history of cough with expectoration, no seasonal variations. History of chest pain on exertion since 3 years, which was diffuse over the precardium, generalized heaviness, at times constricting, radiating to left shoulder. Each episode lasts more than 1 hour. It is not progressive, aggravated in activities, relieved and taking rest. He is also having intermittent episodes of giddiness without loss of consciousness, 2 episodes per week, as in feeling of lightheadedness during the exertion for last 2 years. Not occurred on changing the posture or in supine position. History of an episode of loss of consciousness, syncope, 2 years back, lasted for 2 minutes. Episode was preceded by lightheadedness, not preceded by palpitations. Occurred when patient was doing exertional activities. This episode not associated with abnormal body movements, tongue bite, involuntary urination or defecation, post-episode confusion, nausea or vomiting, no limb weakness, no visual auditory disturbances. No history of pedal edema, abdominal pain, abdominal distension, no history of palpitations, no history of hemoptysis, hoarseness of voice, dysphagia, no history of prolonged fever episodes. This is the present history, ma'am. Past history. It's a known case of hypertension since 3 years. No history of major medical or surgical illness. No history of migratory joint pains in childhood. Personal history, a mixed dietary preference, appetite adequate, bowel bladder habits are normal, sleep was normal. Habits are ex-smoker, ex-alcoholic, quits alcohol smoking since 3 years. Treatment history, since 1 year, he is on treatment with ecospirin AV 75 by 20 mg, tablet Metexil 50 mg BID. Patient underwent the CAG 1 year ago. In CAG report is a mild CAD on medical management. Family history, 5th in birth order. 2 elder brothers expired at 20 years of age. 1 younger brother expired at 55 years of age. Cause was unknown. The patient, third child, have 38 years of age. He diagnosed as CAD anterior MI 2 years ago, thrombolized with tenectoplase. At that time, CAG done. CAG report is recanalized LOD on medical management now. This is the pedigree chart. It shows the 2 elder brothers are expired at earlier age, 28 years of their age. One younger brother expired at 55 years of age. Cause was not unknown. The summary is 70 years old male patient presented with exertional dyspnea for 3 years, progressing from class 2 to 3, chest pain on exertion for 3 years, giddiness on exertion for 2 years with 1 episode of syncope, strong family history of sudden cardiac death. This is the history, ma'am.
Yeah, what are your possibilities, Dr. Sudarshan?
Yes, ma'am. It's a valvular heart disease, severe aortic stenosis. And second possibility is HOCM, hypertrophic obstructive cardiomyopathy, ma'am.
Okay. When do the hypertrophic cardiomyopathy patients generally present?
Sudarshan,
Generally present at adolescents age group, ma'am, after the 18 years of age, around 18 years of age, ma'am. 18 to 30 years of age.
Second and third decade generally.
Yes.
Is it not? Why are you considering hypertrophic cardiomyopathy? Of course, symptoms are very much suggestive of a LVOT obstruction, basically.
Yes.
Understand that. But HOCM patients, it's unusual to present at this age group, right?
Yes, ma'am. Yes.
It is generally in second and third decade that they present.
Yes, ma'am.
Why do they present so early in life as compared to your valvular aortic stenosis?
Because of systolic anterior motion of mitral leaflet, LVOT obstruction will be possible.
The why presentation is early. See, maximum, myocardial hypertrophy happens during the formative years or the growing period, that is adolescent period.
Adolescent, yes.
That is the reason they present in second or third decade generally.
Yes, ma'am.
And you said dyspnea as the predominant symptom.
Yes,
right?
ma'am. Yes, ma'am.
Which symptom will be earlier in aortic stenosis, which was your first possibility?
Chest pain is the first symptom, ma'am.
Generally, it will be
Chest pain.
angina.
Then
Next symptom.
syncope and dyspnea is the last symptom.
Dyspnea is the last symptom. Here it is, dyspnea is the predominant symptom.
Yeah.
So, why do you think patient has developed dyspnea?
Dyspnea maybe one is the diastolic dysfunction, one possibility, ma'am. Second one is the development of the mitral regurgitation causing the increased pulmonary capillary wedge pressure.
Okay.
Other thing is because of
Are you thinking of multivalvular disease as well? See, when
yes,
you
ma'am.
say dyspnea as the presenting symptom,
yes,
do
ma'am.
you want to
Associated
think
with
of
mitral
only isolated aortic stenosis or
associated with mitral
multivalvular? We don't know the diagnosis.
Yes, ma'am. Associated with the mitral stenosis.
Right?
Mitral, yes, ma'am.
Yes, because dyspnea as the presenting symptom or the dominant symptom, I think we should be thinking of associated mitral valvular disease as well. Of course, later on, patient has developed angina and
Yes.
syncope or pre-syncope that is more suggestive of LVOT obstruction.
Yes, ma'am.
Presenting symptom being dyspnea, I think we are justified in thinking of associated mitral valvular disease,
Yes, ma'am.
right?
Yes,
But that was not in your possibilities. I think you should be thinking of that.
yes,
Okay.
yes, ma'am.
And you said in the past history, patient was a hypertensive. I think hypertension and diabetes is for life.
Yes.
It's not like it's in the past history. It should be in that presenting history itself.
Yes.
Are you not thinking of ischemic heart disease as a possibility?
Yes, ma'am. Ischemic heart disease is also possible, ma'am, but because of long duration of the symptoms,
That is quite well known as a typical angina.
yes. Yes, ma'am.
Do you expect dyspnea? At what level of ischemic heart disease do you get dyspnea, or do they present with dyspnea?
Yes, ma'am. LV
With the
systole.
onset of LV dysfunction.
Yes, ma'am.
Right. Because of his age, I think you should be thinking of that possibility. Rather than HOCM as the second possibility, you should be thinking of ischemic heart disease.
Ischemic.
What
Yes.
Dr. Anupam has to say?
Yeah, I was actually I was thinking of asking, don't you think it could be ischemic cardiomyopathy? Because although you said that coronaries were normal or mild CAD, but still coronaries can be recanalized after acute MI. And also strong family history, although it does favor hypertrophic cardiomyopathy, but still, if we look at the commonness of the disorder, because history of CAD also can be there in families, So I think in your differential diagnosis,
Yes.
this should have been there as an essential part to be excluded, because primary ischemic cardiomyopathy or dilated cardiomyopathy, any of these things can present with
Yes.
history of similar history, especially when the dyspnea is predominant symptom and
Yes.
is the earliest symptom to appear in this case,
Yes, ma'am.
isn't it?
When do you expect syncope or a pre-syncope in an ischemic heart disease?
So associated with arrhythmias, ma'am, associated with severe LV dysfunction, hypotension, whether bradyarrhythmias or tachyarrhythmias.
When cardiac output comes down, or it could be arrhythmias.
Arrhythmias.
Agreed. Any other possibilities which you would like to think of? Because dyspnea is the predominant symptom.
Yes.
Of course, there is angina, which is very classical, the way you are describing it.
Yes, ma'am.
Any other possibilities? Maybe a remote possibility. Any right-sided heart disease which you would like
Yes,
to
ma'am.
think of?
Pulmonary arterial hypertension
Right.
also possible, ma'am.
Okay.
But right heart failure symptoms are not there, ma'am. No history of pedal edema, no history of abdominal distension is not.
What are the causes for possible angina in pulmonary hypertension? If you want to think of
One is
pulmonary
the
hypertension as a possibility.
RV ischemia, right ventricular ischemia, ma'am.
Yes. Any other possibilities? Can a dilated pulmonary artery compress the coronary?
Yes, yes.
In what situation? Where do you expect dilated pulmonary artery? Very much dilated pulmonary.
ASD,
Any shunt lesion?
ASD we can expect, ma'am. Atrial septal defect.
Definitely. Eisenmenger situation. Generally,
Yes.
Very much dilated pulmonary artery. It
Yes.
can compress the left main. See, I have seen a patient, Eisenmenger's, presenting first time with this typical angina. And, we made a diagnosis of pulmonary hypertension, but, patient was denying all other symptoms and she was telling about only angina. That is also possible. And
Yes.
pre-syncope and syncope, can you explain with pH?
pH because of hypotension.
Definitely, yes. Yes, reduced cardiac output.
Yes.
Even though it is low in the list because your symptoms are very much suggestive of a left-sided heart disease, dyspnea, angina, and the syncope. I think lower in the list, we should keep this possibility as well.
Yes.
Is the patient a diabetic? Is not a
No.
diabetic.
Not a diabetic, ma'am.
You said he is a smoker and an ex-alcoholic.
Yes, ma'am.
Do you think that history of alcohol consumption has any relevance retrospectively? If you think you would have made some diagnosis, what is its importance in this? Yes.
So maybe it is causing the alcoholic cardiomyopathy, one possibility, ma'am.
Okay. Alcoholic cardiomyopathy is a possibility. Then anything else? Alcohol has any connection if patient has a dynamic LVOT obstruction?
Yes, ma'am. It decreases the preload. So by LVOT obstruction will be increased, ma'am.
Correct. So it causes vasodilatation. So it can precipitate LVOT obstruction. You can have patients typically coming with history, like after a bout of alcohol, they become more symptomatic. And that should be part of your advice as well, that they should totally avoid, because an asymptomatic patient can become more symptomatic with alcohol consumption.
Yes.
Definitely. Anything else with respect to smoking?
Smoking.
Do you want to think of associated lung disease and cardiac disease? chronic
Yes, ma'am.
smoker.
Carpulmonal can be
Because Dr. Anupam was telling about ischemic heart disease as the first possibility. Because of the age, we have to think of that,
Yes.
right?
Yes.
Same time, chronic smoker, it could be like ischemic heart disease plus, because you don't have PND and orthopnea, right?
Yes, ma'am. Yes, ma'am.
PND and orthopnea history is not there. If it
Not
were
there.
to be mitral valvular disease, which valvular heart disease you would have thought of in mitral stenosis or regurgitation?
Mitral stenosis.
Stenosis. So stenosis, patient would have had PND. In this case, it is not there, right?
Yes, ma'am.
So we can as well think of a combination of two things. In a chronic smoker, it could be COPD issue with ischemic heart disease going on,
Yes, ma'am.
right? That is a possibility, and we get to see the scenario in clinical situations. Correct?
Yes. Yes.
Any very rare disease, because the age of this patient is not matching with your first possibility of hypertrophic cardiomyopathy, or I think you kept it as a second possibility, right?
Yes, ma'am.
And valvular heart disease you kept as first possibility.
Yes,
So
ma'am.
valvular heart disease, you meant rheumatic or something else?
Degenerative, ma'am, because of
Degenerative aortic valve disease, right?
aortic
So
valve.
obviously, when you said it is uh, exertional giddiness, so you are thinking of degenerative aortic stenosis, right?
Yes,
But
ma'am.
any rare possibility, very, very rare diseases which run in family, and then they present with similar features, dyspnea and arrhythmias causing fainting or giddiness, uh, which are very close to HCM in the differential diagnosis. Is there something of that kind which is coming to your mind? I repeat,
Yes, ma'am.
something which runs in families
Yes, ma'am.
is
Yes.
very close in differential diagnosis of HCM. It causes arrhythmias, causing giddiness, dyspnea, and similar presentation.
Yes.
Anything of that sort is coming to your mind?
Arrhythmic.
I give you a hint. Yeah, say it. Okay, I give you another hint. Suppose you do echo.
Yes,
Even
ma'am.
then, you are not sure that this is HCM or something else. Or you feel it is HCM, but still you would like uh, to keep it as a differential diagnosis. Anything like that, which is over last 4 or 5 years, that diagnosis has become very popular, and a lot of literature has appeared. Earlier,
New
it was
drugs
not.
have come for the
Yeah,
disease.
new drugs have come.
Most
So
expensive drugs.
most expensive drugs, and something, can you think? Uh, and one of the varieties it typically presents in advanced age group. There are,
Cardiac amyloidosis, ma'am.
Yes.
yes,
Yes.
very good.
Yes.
Yeah, amyloidosis, especially transthyretin amyloidosis,
Transthyretin.
isn't it?
Yes.
And light chain amyloidosis also, especially the latter one presents in advanced age. They present with lot of neurological symptoms, and familial history can also be there because amyloidosis has sometimes gene
Yes.
morphologies which are associated, and it may run in families also,
Yes.
isn't it?
Yes, ma'am.
Right.
So Dr. Anupam was telling that it can be confused with HCM. So what should alert you to the possibility of amyloidosis? Suppose you see, so what are the red flags? When do you suspect? What do you find in
Yes.
history?
History.
Generally, elderly patients almost dyspnea
Yes, ma'am.
is a predominant
Distance
symptom.
freedom. Yes.
They can have
ECG.
angina, they can have syncope, they are at risk of arrhythmias.
Yes, ma'am.
So clinically, when do you suspect amyloidosis? How do you suspect amyloidosis?
And you have to suspect, because if you look at the literature, especially American literature, about 25 to 30% of the cases which are diagnosed as HCM, they actually has amyloidosis,
Yes.
isn't it?
Yes.
So uh, now because unless you have a suspicion, unless you know the clinical reasons to suspect, every patient cannot be subjected to the tests, because tests are not very specific, and they are very expensive tests to rule out amyloidosis, isn't it?
Yes.
Drug treatment is also now there, but that is
Yes.
also expensive. So you have to have some clinical suspicion. So
Yes.
what are those features which will make you think that this patient should necessarily undergo testing to rule out amyloidosis? Can you think of something?
Yes, ma'am.
Sudarshan, in history, like
Yes, ma'am.
something makes you suspect amyloidosis.
Yes, ma'am.
Then when you do ECG, you
Low
expect
voltage QR.
something else will be there.
ECG low voltage QRS complex.
Low voltages.
Yes,
Okay. You can have, low voltages.
Something refine. A bit, can you refine low voltage in which leads and high voltage in which leads?
Low voltage
There
in
is a very specific sign in the ECG which suggests especially transthyretin amyloidosis.
yes, ma'am.
Have you heard of that sign? Something in limb leads and something
Limb
in
leads,
chest leads.
limb leads low voltage QRS.
One of the classical feature of the amyloidosis, as Madam is saying, is that ECG low voltage complex and the neck mova is the thick areas,
Hypertrophy.
especially interatrial septal thickness will be there very much. One thing I want to add is, in addition to the congenital, don't forget about the abstinence. Abstinence can be presented at any time, and it can be the presentation at the 70 years. And the syncope is because of the WPW syndrome associated with that. And dyspnea, chronic dyspnea is the some of the presentations. And as you know that the ischemia is also known to occur in the abstinence. And in the long-standing, especially elderly, abstinence is known to be involved in the left ventricle also, not because of the abstinence, because of the long-standing hypertension and the effects of it. So they can have those features also. Yeah, please go ahead.
Yes, thank
And
you.
also a congenitally corrected TGA. It also fits
CCT.
into all of yours, but 70 years.
Yes, ma'am. General examination, ma'am. Patient is conscious, coherent, oriented to time, place, person, moderately built, moderately nourished, height 170 centimeter, weight 60 kgs, BMI 20.76 kg per meter square. No anemia, no icterus, no clubbing, no cyanosis, no lymphadenopathy, no edema, no musculoskeletal abnormalities, no Marfanoid features. Vital data: pulse rate 60 per minute, regular, normal volume, brisk, rapid rise, no radioradial, no radiofemoral delay, thickened arterial wall. Carotid pulse is a Besparians in character, no carotid thrill. All peripheral pulses are palpable, no peripheral signs of aortic runoff. BP, blood pressure, right upper limb 130 by 70 mm of Hg, left upper limb 120 by 70 mm of Hg, right lower limb systolic blood pressure 138 mm of Hg. Respiratory rate 18 per minute, regular abdominothoracic type. Saturation 98% with room air. Temperature was normal. JVP 2 centimeter above the sternal angle at 45 degrees with normal waveform, 2 positive waves, 2 negative waves, A and V, X and Y wave pattern. With normal respiratory variation, hepatojugular reflex is negative. Systemic examination. Inspection.
Darshan, just a minute. At the
Yes.
level of general physical examination, what is your inference? What are the positive findings and what you can infer at this level?
Yes, ma'am. Pulse, based on pulse, ma'am, it is a brisk and jerky and Besparians pulse. No
It's a
peripheral.
jerky pulse. What are the situations where you can get jerky pulse? What are the conditions where you expect jerky pulse?
So we'll get in the HOCM and hyperdynamic states also can be.
Hyperdynamic states means?
So like anemia,
You mean to say high volume collapsing pulse, but jerky is different from that.
Yes, ma'am. Rapid rate of fall and pulse with the low volume.
Mini water hammer. Where do you get this mini water hammer or a rapid upstroke? Chronic severe MR.
Chronic.
You know,
Yes,
it can be just a rapid rise or a mini water hammer, we call it as. There you can have a brisk pulse.
Brisk. Yes.
Otherwise, in a chronic AR, if you are talking of, it will be high volume collapsing.
High volume.
Here, volume is normal. You have written volume is normal, right?
Yes, yes, ma'am.
So, where else do you get bispherians?
Severe
What are
AR,
the situations where you get bispheria?
severe aortic regurgitation, ma'am.
Okay, chronic severe AR.
Chronic severe AR, chronic severe AR with moderate AS and HOCM, ma'am.
HOCM. How is it different in HOCM from chronic severe AR?
So in HOCM, the first, there's a 2 peaks in systole, ma'am, percussion and.
Is it the same?
No, ma'am. It is a.
What is a bispherians pulse?
It is a 2 peaks in systole, ma'am. Percussion wave, tidal wave in the systole, ma'am, appearance.
Sorry?
It is in HOCM, it is a better recordable, ma'am, rather than palpable compared to severe AR.
Anupam,
Can I
ma'am,
continue?
you want to ask him something, ma'am, or will ask him to continue?
I think, yeah, he can continue.
Yes.
Okay.
On systemic examination, inspection, chest is normal in shape, bilateral symmetrical. The transverse diameter more than AP diameter. Apical impulse is visible in the left fifth intercostal space, 1 centimeter medial to the midclavicular line. No other visible pulsations, no scar sinuses, dilated veins. On palpation, apex bit is confirmed in the left fifth intercostal space, just inside the midclavicular line. It is sustained, heaving type, bifid in character with a double apical impulse, and LV type with medial retraction. Palpable presystolic impulse present at the apex. No palpable S3 or other sounds. A systolic thrill palpable at left, third, fourth intercostal space. No any other pulsations, no left parasternal heave. Percussion, liver dullness present in right fifth intercostal space in midclavicular line. Left to second intercostal space is resonant. Left cardiac border corresponds to line joining from the left to second intercostal space to the apex. Right cardiac border corresponds to the right sternal border. Auscultation, first heart sound is normal. Second heart sound normal split. Both aortic and pulmonary components normal in intensity. A low pitch presystolic sound, LV, fourth heart sound, is audible at apex with bell of the stethoscope in left lateral position. No other sounds. A grade 4/6 hours, medium pitch ejection systolic, crescendo decrescendic murmur, peaking late in systole, best audible in left third, fourth intercostal space, not radiating to carotid, better heard with the diaphragm of stethoscope. On dynamic auscultation, murmur increases with the strain phase of Valsalva maneuver on standing and decreases with the squatting and passive leg raise and hand grip. A grade 3/6 soft blowing, high-pitched pan-systolic murmur audible at apex, radiates to axilla, better heard with the diaphragm stethoscope in left lateral position and expiration. Other system examination, respiratory system, clear bilateral normal vesicular breath sounds are heard. Per abdomen, no tenderness, no organomegaly. Central nervous system, no focal neurological deficits. Bilateral plantars, plexors. Final diagnosis, ma'am. Severe dynamic left ventricular outflow tract obstruction at subvalvular level. Hypertrophic obstructive cardiomyopathy with moderate mitral regurgitation. No significant pH, not in CCF, in sinus rhythm, NIHA 3 now, with a strong family history of the sudden cardiac death.
Okay, so now with this clinical background,
Yes.
are you sure it is hypertrophic cardiomyopathy, or you still would like to see some investigation in ECG or X-ray, or what would you like to see next?
Yes, ma'am. It is a sure, ma'am. Hypertrophic.
Sudarshan, sorry, there was some network issue.
Yes, ma'am. Yes.
Was it discussed bispherians pulse, or is it different in bispherians of AR and HOCM?
Yes,
No,
ma'am.
that was please say it again, Dr. Sudarshan.
Yes, ma'am.
That please answer that question.
Yes, ma'am.
The
Yes,
difference between bispherians of AR and bifid pulse of HOCM.
yes, ma'am. In HOCM, first there are 2 peaks in systolic phase, ma'am. HOCM,
Is it?
HOCM, it is a first peak is longer than compare with the second peak, ma'am.
Both the peaks are in systole, you are telling, in HOCM?
No, in Bisperian's pulse means two peaks in systole, percussion wave, tidal wave in the systolic phase, ma'am.
No, Baba. AR also you get Bisperians, you said. How is it different in HOCM from AR? You said double apical impulse, right?
Yeah. Yes, ma'am. Yes, ma'am.
What gives rise to the second impulse here?
Second impulse is a related to dichrotic notch.
No. Apical impulse I am asking. See, go back to your physical findings.
Yes, ma'am.
Yeah. Apex beat, you say. Apex beat.
Yes, ma'am.
Sustained heaving, bifid in character with double apical impulse. What
Yes,
is the cause for double apical impulse? Why are you feeling the second impulse?
So percussion and tidal wave is more prominent. Both waves are more prominent.
See, that is pre-systolic. You are commenting on S4, no?
Yes, ma'am. Yes, ma'am.
Right? It is a non-compliant, I mean, very compliant LV, hypertrophied LV, no? So it is basically
Yes,
a
ma'am.
pre-systolic impulse, right?
Yes, ma'am. Yes, ma'am.
That is giving rise to double apical impulse. Can it be triple as well?
Triple associated with S3 can in LV systolic failure. HOCM with LV
S3 do you
systolic.
expect?
Mainly in HCM with systolic failure.
No, that is very late. That is very
Okay.
late. I think you should go back and read about it. It can be double or triple ripple. It is called triple ripple, right?
Yes.
You have heard of that?
Yes, ma'am. Triple.
So you should know the mechanism. It can be double or sometimes it can be triple as well.
Triple.
Yeah, go to the next slide. I'll take a minute. Some network issue got disconnected twice. Yeah.
Yes, ma'am.
And please don't use that word systolic two waves. That is tidal and percussion wave. You doesn't get in a apex beat palpation. That is an arterial
Yeah.
description.
Okay.
So
Yes.
you're talking about apex beat. Don't use those two words.
Yes, ma'am.
See, Bisperians in HOCM, you will get one peak in systole, one peak is in diastole,
Yes,
right?
ma'am. Yes, ma'am.
Aortic regurgitation, you get it both in systole.
Yes, ma'am.
I mean, sorry, diastole. Not diastole, systole, sorry.
Systolic.
Yeah,
Yes,
here
ma'am.
it is different. Both are Bisperians, but it is different in HOCM from AR.
Yes, ma'am.
Yeah. You said 3/6 blowing murmur, which radiates to axilla. Do you expect that generally where should it radiate? What is the cause for mitral regurgitation in HOCM? What's
HOCM
the
is
mechanism of
because of systolic anterior motion of the anterior mitral leaflet, ma'am.
Correct. So where do you expect the jet?
So jet can be radiated to the.
Is it an eccentric jet?
Yes, ma'am. It is eccentric jet. It can be radiated to the
The posterior.
posterior.
It goes posterior.
Posterior.
What if it goes anteriorly? Can you get anterior jet as well? Is that possible? Central or an anterior jet?
Yes, ma'am. Possible.
So, in addition to your this thing, anterior systolic motion, there can be mitral valve abnormalities as well, right?
Yes, ma'am.
What are the mitral valve abnormalities you can expect in HOCM?
Anomalous papillary muscle.
Correct.
Papillary muscle
Yeah, it can be elongated anterior mitral
leaflet.
leaflet. Yeah, the other abnormalities can be there where you can get
Mid-cavitary obstruction.
anteriorly directed jet or a central jet. Yeah,
Central.
go on next.
Yes. This is the final diagnosis, ma'am. Can I go to ECG, ma'am?
Can you expect pH in this case? I expected pH actually, but you say no significant pH.
Yes, ma'am. Clinically, no signs, ma'am.
There is no evidence of pH.
No evidence, ma'am.
Can you expect pH?
Yes, ma'am. Because of mitral regurgitation, pH possibility. Other thing is a
Even in the absence of mitral regurgitation, can you expect pH? It's because of the diastolic
diastolic
dysfunction itself.
dysfunction. Yes, ma'am.
Diastolic dysfunction.
Yes,
So
ma'am.
1/3 of these patients with aortic stenosis or LVOTO, they can have pH with preserved LV function as well. Yeah, you can go to the investigations. Yeah.
Yeah, two things requires to be the description. In HOCM, you have to say what is the degree of the LVOT obstruction, whether it is there or not. HOCM can be there without clinical
Obstruction.
manifestations of the LVOT obstruction. If it is LVOT obstruction is there, you should say about the severity.
Yes.
You have not mentioned anything about it.
It is a
Hypertrophic cardiomyopathy, as you know, that the variants are there. Like it can be the apical, it can be midcavitary.
yes,
So
ma'am.
the
Mid-cavity.
LVOT is an obstruction,
Yes,
and
ma'am.
the degree of the LVOT obstruction to the degree of the NMR. All these things are also requires a mentioning, as madam is mentioning, primary intrinsic pathology of the mitral valve may be responsible for the NMR, may not be related to the SAM. So all
Yes.
these things, your complete diagnosis should include it.
Yes, ma'am.
The patient has LVOT obstruction or not.
Yes, ma'am. Patient have LVOT obstruction.
So you said hypertrophic obstructive cardiomyopathy. Now you
Yes, ma'am.
say that the severity of the obstruction. Always you classify, no? The AS is there. You will classify
ma'am.
mild, moderate, severe. You should classify it.
Sudarshan, suppose
Yes,
this patient, you were not to hear that ejection systolic murmur, what
Yes,
you would
ma'am.
have done?
Oh, we have to do dynamic
Because
auscultation.
patient is highly symptomatic and you had a high suspicion of HOCM, but
Yes, ma'am.
suppose you are not to hear that murmur, what you could have done? Is that possible?
Yes, ma'am. Possible, ma'am. Dynamic auscultation I can do, ma'am. One is the
Okay, you
Valsalva,
have done dynamic auscultation.
one is the Valsalva maneuver and standing.
Okay, so you have to do some provocative thing, is
Yes,
it not?
Yes, ma'am.
So on provocation, gradients,
Gradients will be increased.
obstruction appears.
Obstruction appears. Yes.
Yes, otherwise it's
Yeah.
quite possible that we hear no murmur or a very mild murmur, and we have to do some provocative tests, and
Yes.
LVOT obstruction will show up.
Sure. Yes.
Yeah,
The
you
major
should
problem
be
in
aware of that.
Yeah, the major problem in hypertrophic cardiomyopathy is to classify the severity. Like in AS, if you have the S4,
Well-
yes, it is corresponding to the this much of the gradient of the aortic. That is not so in the case of the hypertrophic cardiomyopathy. You can have an S4 without an obstruction, and
Yes.
you can have then a prolonged ejection murmur with a mild gradient, especially
Mild.
associated with another the diseases.
Yes.
And you can have the double apex, as you are already described. Only the hypertrophy can produce a double apex and without an obstruction. So it is very difficult to say the degree of the LVOT obstruction, like in AS and hypertrophic cardiomyopathy. But try to attempt to say it, like the patient has the S4 in the presence and a prolonged and a late picking of the systolic murmur, which is a feature of the severity of the obstruction. So these
Yes.
two are the features, and if the split is in a favor, like there is a paradoxical split is there, then
Yes.
you can be much more certain that is more severe LVOT
More
obstruction.
severe. Yes.
So you say that it is difficult in a hypertrophic cardiomyopathy to say the LVOT obstruction, but because of these presence of these two features, may be a severe. Is
Yes,
acceptable one. Yeah, please
Yes.
go.
ECG, ma'am, is a 12 lead normal standardization. The sinus rhythm, heart rate around.
Maybe you can tell only the positive findings.
Yes, ma'am. Heart rate is 60 per minute. So left atrial hypertrophy is there, and left LV hypertrophy is present with a strain pattern.
Okay. Anything else? What other ECG features you can expect or this patient has? Can you expect some Q wave somewhere? There is some ST elevation I am seeing in lead 3 and AVF. Can they have pseudo-infarction patterns? Left atrial activity. They can have Q waves in V1 to V3. Is it there in V1? No, we are seeing a small r. But don't you think 3 and AVF has some ST elevation? Some ST elevation is there. What, Dr. Anupam?
Definitely, it is, yeah, it is
3 and AVF.
pseudo-infarction pattern, which is very typical in these patients with in inferolateral lead.
Yes,
Yeah,
ma'am.
so
Yes, ma'am.
comment on the ECG features in lead 3 AVF, and also what do you think is the axis?
Axis is the normal axis, ma'am. It is around 10 degrees, ma'am. It is.
Just
Sure.
project the ECG again.
Yes, ma'am. Yes, ma'am. Is it
Can you
visible?
project the ECG again? Share your screen. Now, can you tell us what is the axis?
Axis is QRS axis is 10 degrees, ma'am, because it is a equiphasic between the 1 and AVL.
Where is it equiphasic?
Where is it equiphasic?
No,
I
no, it
can't
is a
see
high
any
voltage.
equiphasic.
No, it is a high voltage between the high voltage leads. It is a 1 and AVL.
No, how do you see axis? Don't you think this is left axis?
Yes, ma'am. One is positive, AVF is negative.
Hmm.
Uh,
So what do you think is the axis? Left axis deviation?
so it is a but
It's more
it is
positive. Lead 1, the voltage is more
Yes.
towards, positive.
positive.
Yeah. Is there any left atrial activity as well?
Left atrial.
Do you expect left atrial enlargement?
Yes, ma'am. As an lead V1 is a negative deflection is more than 1 millivolts, and bifid P wave in the lead 2.
It's not clear for us actually, but
Yeah.
you can
Actually,
expect.
looking at this ECG, I think hypertrophic cardiomyopathy is not, it's not a classical ECG suggestive of
Yes, it is not.
hypertrophy. Yeah. And what you said, something 1 millimeter for P wave in V1. What
Yes.
is that called? Is it only 1 millimeter or something else?
So negative
Or some,
deflection.
yeah, that's
Bifid.
P
What do you
terminal
call that
force.
as?
What is that called? What is that index
What
called?
index is it?
Morrison's index.
Sorry?
Morris index.
Morris, not
index.
Morrison. It is Morris index, right?
Morris index.
And
Yes.
it
So
is,
you're
you have
looking
to say
at
1 millimeter square, isn't it? Because it's not only the depth.
Yes.
1 millimeter into second
Second.
or 0.04. If you multiply, you call it in millimeter second. Otherwise, you call it, if you can calculate in squares also, Morris
Yes.
index, right?
Yes.
But do you think this
Definitely.
ECG is satisfying the LVH criteria?
Yes, ma'am. It is a Sokolov-Lewin index positive, ma'am. It is around more than 35 mm. S wave in V1, R wave in V5. And Cornell voltage criteria also positive, ma'am.
And definitely you should not miss out this ST elevation.
Hmm.
Lead 3 and AVF.
Yeah. Yes.
Yeah. Yeah. Pseudo infarction patterns are known. Even in lead V1 also some ST elevation is there. Pseudo infarction patterns are also seen in
Yes.
HCM. Can you
Yes,
get some pre-excitation as well in HCM? Is it
Pre-excitation.
known?
Yes, ma'am.
Is it known? Okay, it's a homework for you to find out.
Yes. Can I go to X-ray, ma'am?
Yeah, please.
Yes, sure.
Yes, ma'am. It is a chest X-ray PA view with no cardiomegaly with LV type of apex. So prominent bronchovascular markings. So no other specific finding.
Is it over-penetrated?
Yes, ma'am. It is a
Normal penetration?
It is
Over-penetrated. So, yeah, commenting on the vascularity is, difficult. Or whole of the spine we are able to see, right?
Yes.
So, over-penetrated here.
Okay.
Is there any evidence of pulmonary venous congestion? That's what I am interested in. patient's predominant symptom is dyspnea.
Yes, ma'am. No.
So vascularity only, it is difficult to comment for us.
Yes, ma'am. No cephalization of pulmonary vessels, ma'am.
Actually, if penetration is not proper, our comment on vascularity is not proper.
Yes.
I think nothing contributor. It looks like LV hypertrophy pattern to me.
Yes.
Do you think there is
Nothing.
left atrial enlargement?
Here, there is a left atrial enlargement is there, ma'am, because tightening of border is there here.
Is it?
And also no widening of carina angle, ma'am. No left, not that much prominent, ma'am. And also no double shadow, double density shadow is not there, ma'am.
Okay, so
From
this
here,
is
I'm
more or
not
less
able to make out
unremarkable.
really.
Yes,
Yes, yeah.
It's an unremarkable X-ray. It doesn't give us any clue to the diagnosis, isn't it?
Yes, ma'am. Yes.
Except for mild cardiomegaly. Yeah.
Mild cardio.
So what
Lungs
next would you
look
like to?
Can I go to echo, ma'am?
Yeah, sure.
So, this is the
I
flax
thought
tree.
intraatrial septum is thicker. No, in the first one of the pictures. I don't
Yes.
know.
Yeah,
Yes, ma'am.
Huh?
looks like.
This is not looking like the typical HCM to me.
Yes, to me it's looking actually that ECG was also not like classical of HCM. So, okay.
If you have
There
any
is,
original files, 1 or 2, if you can just play the videos,
Yeah,
you not even need the PPT.
correct. Correct.
Not playing. Okay, I think go to the M mode picture.
Yes, ma'am.
M mode.
Even the leaflets, even the valves appear thickened.
Hmm.
Can you
Yes.
go back to that? The previous picture?
Yes, ma'am.
And even RV wall is thickened.
Yeah, see the
Right
leaflets
ventricular
also.
free wall also.
Are you sure of your
Ma'am?
this ejection systolic murmur
Yes,
shows
ma'am.
the gradient?
Yes, ma'am. There is a.
Where is the turbulence and
Yes, ma'am. Here
this
LVOT.
is like
This
okay,
is
dagger
Dr.
shaped. Yeah.
Dagger shaped curve is there. And also more than 30 mm of edge
Gradient
gradient.
is not much actually.
Yes, ma'am.
Not touching even 4 meters.
Yes, ma'am.
It doesn't have the histo characteristic. I wish we had the running pictures.
And also
So,
diastole dysfunction is
Flax again.
Diastolic dysfunction, of course. That
diastolic
will be there.
dysfunction.
Mitral regurgitation, can you show us?
Yes, ma'am. It is a mitral regurgitation area is 6.7 ma'am centimeters.
Moderate mitral regurgitation.
Yes, ma'am.
What is the thickness of the interventricular septum?
It is a 2.48, 2.5 ma'am.
Okay.
On PWD it is a 1.5 ma'am. It is a ratio is more than 1.3.
It is basically asymmetrical septal hypertrophy.
Yes, ma'am. And also
any other part of left ventricle is hypertrophied?
No, ma'am. Only septum only is hypertrophied. No apical LV hypertrophy, ma'am.
But you said PW is 1.5. Is it not hypertrophied?
Yes, ma'am.
PW you said.
Yes, ma'am. It is hypertrophy. Hypertrophy. Asymmetrical septal hypertrophy.
Okay. What else do you see in this M mode?
M mode, there is a systolic anterior motion of the mitral leaflet, ma'am. And also
What's the grade of systolic anterior motion?
It is a grade 3, ma'am. It is a less than 30% of systole, ma'am. There is a contact between the IVS and anterior mitral leaflet is less than 30% of systole.
Okay. That MR which you have measured looks like overestimated because the area is going beyond the turbulence, and it is causing 3/6 murmur. Maybe okay.
Any mitral valve abnormality did you see, Sudarshan?
No mitral valve abnormality, ma'am. Normal. Only
So
thickening
MR
of,
is secondary to SAM.
yes, ma'am. MR is
Can you
secondary to
mention
the,
some other causes for SAM other than HCM? Voice also.
yes, ma'am.
In the
Elderly
background.
elderly patients who are in vasodilators and digoxin therapy will get SAM and
Yeah, hypercontractile LV you can.
hypercontractile. Maybe postoperative states without the fluid, IV fluids, with excessive inotropic support, we can get.
Correct. Correct.
And post MVR and post AVR can. Yes.
Yeah, so even with inotropic therapy, you can have
Yes.
this. Yeah,
SAM.
LVOT SAM. Correct.
Yes.
So what are the echo markers of hypertrophic cardiomyopathy? How do you make a diagnosis of hypertrophic cardiomyopathy in echo?
Yes, ma'am.
See,
Yes,
there
ma'am.
can be a lot of overlap, right?
Yes, ma'am. Yes, ma'am. So,
Yeah, what are the pointers towards hypertrophic cardiomyopathy?
yes, ma'am. Interventricular septal diameter is should be more than 15 mm, and if suppose family history, strong family history, and sarcomeric gene variant carrier, it can be 13 mm enough, ma'am. Interventricular septal diameter, and
Okay.
ratio of the,
Yeah, it can be lesser than 15 mm.
yes, ma'am. And also ratio of the septum and posterior wall thickness would be 1.3:1, ma'am. And
Okay, more than 1.3, right?
yes, and
Diastolic dysfunction.
diastolic dysfunction should be present, ma'am.
How do you distinguish it from athlete's heart?
So athlete's heart,
You know, you have many patients who are like who present to you
yes, ma'am.
and they would be exercising well, and you know, you have confusion. There can be overlap. What are the differentiating points?
So in HOCM, LA enlargement present, ma'am. In athlete's heart, no left atrial enlargement, ma'am. It should be less than 40 mm in athlete's heart, ma'am. And
They can have LA enlargement.
yes, ma'am. And also LV diameter during the diastole, it is a less than 45 mm in HOCM. It is a more than 45 mm in athlete's heart, and LV that is a post.
See, you get chamber dilatation, cavity dilatation. Cavity will be small in HCM.
HCM,
right?
yes, ma'am. Yes, ma'am.
Here, there will be eccentric hypertrophy. There will be both dilatation and hypertrophy in athletes. And
yes.
even LA can be dilated. LA can be bigger.
Yes. No diastolic
Yeah,
dysfunction.
that cannot be the differentiating point. Yes?
No diastolic dysfunction in athlete's heart, ma'am. In diastolic dysfunction.
No diastolic dysfunction.
Yes.
And
Anything
also, else?
Interventricular septal diameter is less than 15 mm IVSD in athletes. No?
So hypertrophy will be not much. Sometimes there can be an overlap.
Yes, ma'am.
So deconditioning. Suppose patient stops exercising, it can regress. The changes can regress. That can be a differentiating point.
Yes.
What are the other differentials for HCM? Like just now we were discussing about amyloid.
Yes, ma'am.
So what do you get in amyloid? Elderly patient, as Dr. Anupam rightly said, we have to keep that in mind. Of course, you are getting gradient across LVOT here. Otherwise, that was a strong possibility in this patient. What are the differentiating points?
Interatrial IAS septum thickening can be get, ma'am, and amyloidosis.
Yes.
And also,
what else can be there?
So there is a diffuse hypertrophy of the LV with some haziness.
Haziness or something else
Mosaic,
in the myocardial texture, something described.
Mosaic pattern.
Mosaic. No, not mosaic, something else. Speckles.
Speckles.
Myocardial speckles. And what do you get?
Speckled appearance. What else?
What else? Something
so you
in
can have involvement of the valves, AV valves. So you can have mitral regurgitation, tricuspid regurgitation.
Yes, ma'am.
You can you have involvement of the pericardium?
Yes, ma'am. Thickening,
They can have pericardial effusion.
effusion. Yes, ma'am.
Pericardial effusion they can have.
Yes.
And the tissue
Okay, all
Doppler
these
is an
features.
important thing actually for the athlete hearts
Amyloid.
to the HOCL, even amyloid or HOCL. So tissue Doppler velocities will be the abnormal in this, whereas in athlete hearts it's not so.
Yes.
So how would you like to differentiate amyloid? Anything different in between HCM and amyloid? You do something else present mostly in the echo machines nowadays? Some other modality of echo which has very characteristic features suggestive of amyloid.
Any
Yes.
other
Anything in
imaging?
strain imaging?
Yes, ma'am. Restrictive pattern of the
Restrictive pattern.
Is it
Restrictive
some-
pattern you will get in the diastolic dysfunction
yes, ma'am.
that you can see even in Doppler, right?
Yes, ma'am. Yes, ma'am.
But something which is specific of amyloid, you do speckle tracking and you see
Have you
that
heard of
something is there.
apical sparing?
Yeah,
Yes, ma'am.
Apical sparing? Hmm?
Apical sparing. Yes,
Hmm?
ma'am.
very,
Which
characteristic.
condition do you get?
Actually,
Out of
previous
these two,
E-class
which condition?
previous E-class Sujata projected that pattern of the amyloidosis.
Out of these two, which one gives you apical
Okay.
sparing?
It's amyloidosis, ma'am.
Okay, what is that called when you do the strain imaging? When you make a map of bullseye map,
Go.
what do you see in that? What is that sign called?
Yes.
Because your generation has to know strain imaging as well as 3D
Yes.
echo, right?
Yes, yes, ma'am.
Correct.
So what is that called? Have you heard of cherry on top?
Yes, ma'am. Yes, ma'am.
Hmm?
Yeah.
Cherry on top. So
Cherry
read
on-
it properly because it may be asked in your exams, right?
Yes, ma'am. Yes,
Just note these questions and prepare them properly, right?
yes, ma'am. Yes.
Okay. Next, shall we start asking treatment?
Yes, ma'am.
Dr. Nagmani, can we start with the treatment part?
Yeah, sure, ma'am. Sure.
So
So
what
how
do
do
you
you
think?
manage the case?
Medical management, ma'am, and surgical management, ma'am. Medical management, drugs is a beta blocker and or
But
calcium
your
channel.
heart rate is 59, isn't it? In the
Yes, ma'am.
ECG.
Yes, ma'am. He is an
So-
already on beta blocker metoprolol 50 twice daily, ma'am. 50 mg twice daily.
Okay.
Okay. Oh, that is on medications. Okay.
Yes, ma'am.
What other drugs can be offered to him?
Disopyramide can be added, ma'am. If LVOT
Calcium channel blockers, you have to tell first. Disopyramide is later in the list. Beta blockers, calcium channel blockers.
Yes, ma'am. Non-dihydropyridine calcium channel blockers, ma'am, like verapamil.
Correct.
Yes, ma'am. Next,
What else?
You have to use maximum tolerated doses.
yes, ma'am.
So in what way it will help?
So it will decreases the gradient, ma'am, LVOT gradients by decreasing the heart rate. So whenever decreasing the heart rate, diastolic filling will be increased. So LVOT obstruction will be decreased.
Do you
Other-
think it's just the heart rate which works
Other
for
thing is
reducing
negative inotropy.
inotropic?
Negative inotropy. So
Negative inotropic effect.
Mhm. Yeah.
so
Okay. Then what else? Just
disopyramide.
quickly go ahead. What all treatment would you give?
Disopyramide also works same as negative inotropy mechanism, ma'am. When combined with
Next.
beta blockers, it is a very effective if resistant case of the decreased LVOT gradients. Next is a
Okay, what are the, you
Surgical-
have used maximum tolerated doses. Patient continues to be still symptomatic.
yes,
What do you do?
we can go the surgical management, either myomectomy or septal
Myectomy, not myomectomy. Myectomy.
myectomy,
Myoma is different.
septal
You're trying to-
alcoholic septal ablation, ma'am.
What are the present day indications for alcohol septal ablation?
So indications for the, even though with the maximal medical therapy, refractory symptoms, NIHA 3 or 4, and there is a septal thickness is more than
See,
18
that is an indication for septal reduction therapy.
septal reduction.
And as we know, nowadays it is only the myectomy. No,
Myectomy.
it's alcohol septal ablation is considered in very rare circumstances. Otherwise, the class 1 this thing is myectomy. So, what are the indications for alcohol septal ablation
Where there is
in
a high,
present time?
there's a surgical mortality is very high with comorbidities.
High surgical risk, yes. Or if the patient is not willing for a surgery.
Not willing for surgery.
Not
Yes.
willing for surgery. Then we have to consider alcohol septal ablation. Can you mention some complications of alcohol septal ablation?
Yes, ma'am. Complete heart block and ventricular septal rupture and myocardial infarction can be possible.
Right. Yeah, we are creating controlled myocardial infarction there, basically.
Yes, ma'am. Yes.
What is a biphasic response with respect to alcohol septal ablation?
There is a regression of the myocardium, fibrosis.
See, initially when you ablate, when you inject alcohol,
Yes,
what
ma'am.
happens to the gradient?
The gradient for reduction of gradient, it will take time for 6 to 8 weeks, ma'am.
Yeah, initially there can be reduction of the gradient.
Yes.
Then again the gradient can go up, and later on follow-up after 4 to 6 weeks, you can see again reduction of the gradient.
Yes.
Initially there will be some amount of myocardial depression,
Yes,
but
ma'am.
then other segments become hypercontractile.
Yes,
So
ma'am.
later on follow-up, you will see again reduction of the gradient. This is called biphasic response.
Yes.
How much amount of alcohol do you use for septal ablation?
0.3 ml 4 times, ma'am. 1.2 ml total.
Yeah, maximum 1 to 1.5 ml. Yeah,
Yes.
1 to 1.5 ml. Okay, what is a prerequisite for alcohol septal ablation?
There is no coronary artery disease, and septal branch of the LAD should be amenable to alcohol septal.
How do you identify that? So you have to identify the target septal,
Targets.
right?
Yes.
So how do you identify the target septal?
So which septal branch is more prominent?
Any test you want to do?
Coronary angiography with
Coronary angiography, you are seeing the vessel.
No.
Then
No,
how
ma'am.
do you know that that is the target
Contrast.
septal? You have to do contrast echo. Yeah.
Contrast echo. Yes.
Contrast echo. It's very, very important, because the another problem with your septal alcohol ablation is what is called as remote infarction.
Remote infarction.
What is remote infarction? So you have injected alcohol into the septum, but it tracks through the collaterals into the another vessel and causes infarction there.
Yes.
Okay.
Yes.
So that is why you have to clearly identify the target septal, and your alcohol amount should be very less,
Yes.
not more than 1.5 ml.
Yes.
Any other modalities for interventional therapies other than your alcohol?
Radio frequency ablation of the septum.
Yeah, radio frequency ablation, and sometimes even they have tried coils. Yeah.
Yes.
Anything else, Dr. Anupam, you want to discuss regarding surgery?
Anything, any other medication which you missed?
Newer therapies?
So newer drug is a mavacamten advised, ma'am.
Mavacamten.
It is a cardiac myosin allosteric inhibitor.
Myosin inhibitor.
Yes.
What is the dose?
Those.
Is it available in India?
No, ma'am. It is a
It is
Recently-
available. It is freely
It is
available.
available. It is available.
It is available. But only thing is it is expensive.
Expensive. Yes.
Expensive.
5 mg per day is the dose, right?
Yes.
Yeah. You can go
Okay.
up to 15 milligram.
15. Yes.
Once a day dose it is. It is available.
Yes.
It's available. You can go up to 50. What is the downside of myosin inhibitor? What is the problem expected with myosin inhibitor?
Myosin.
How it acts? You said myosin inhibitor. How it is going to act?
It is a allosteric inhibitor of the cardiac myocinative.
What will
Okay.
it cause? If you
Regression of,
inhibit myosin, what will it cause?
regression of the growth of the myocardium.
Or immediately negative inotropy, do you expect?
Yes.
Do you
Yes, ma'am.
expect that patient may
Contractility will
develop
come
LV
down, no?
dysfunction?
Yes, ma'am. Contractility will come. Yes.
So patient may develop LV dysfunction, right?
Yes, ma'am. LVD.
Okay. Now this patient has strong family history of sudden cardiac death.
Yes, ma'am.
So what else would you like to do? And what else would you test to see is something else is required? Because the management part of HCM is prevention
Yes.
of sudden cardiac death as well as
ma'am.
reduction of symptoms, right?
Yes, ma'am.
But
Yes.
sudden cardiac death is more important.
Yes,
So
ma'am.
what would you like to do in this case?
Yes, ma'am. Cardiac MRI you can advise, ma'am, and also
Is it
Holter monitoring.
directly cardiac MRI? Would you
No,
not like to? What is
Holter.
your aim of doing cardiac MRI?
So whether late gadolinium enhancement of the myocardium is present or not, how much percentage?
No, okay. So see, this patient already has a strong family history.
Yes,
So what are the features less than or short of cardiac MRI which tell you that this patient requires or he is prone for lethal ventricular arrhythmias
yes, ma'am. For
other
prim-
than LGE?
yes, ma'am. NSVT in Holter monitoring, suppose repeated recurrent NSVT runs 1 point, ma'am. Other thing is a recent recurrent unexplained syncope. So on a exercise test, there is a fall in the systolic blood pressure of more than 10 mm from the baseline. Other thing is if interventricular septal diameter is more than 30 mm, can be considered for the
Thickness.
ICD.
Thickness, ventricular thickness more than.
Thickness more than 30 mm can be considered for the ICD. Ma'am. That is for the primary prevention. For a secondary prevention, ICD can be class 1 indication for the sudden prior cardiac arrest and repetitive ventricular tachycardia status.
Okay, so in this patient, what is your decision? You want
Does
to
he
do
not
MRI first
directly
or
qualify for ICD?
does
Yes,
he
ma'am.
directly qualify or would you like to wait for MRI report?
Yes, ma'am. Family history is positive and
He has a strong family history, what you say as SCD.
yes, ma'am.
Is it not? Keeping
Yes,
that
ma'am.
in mind,
Yes, ma'am.
yeah, there is an indication.
Indication. Yes, ma'am.
And he has one syncope also.
Yes, ma'am.
Two
Yeah.
years back he had a syncope, isn't it?
Yes, ma'am. Yes, ma'am.
So would you like to implant ICD right away?
Yes, ma'am. Class 2A indication. You can cardiac MRI. You can advise, ma'am.
What would you like to see in LGE?
Late gadolinium enhancement and also
How much?
so more
How
than
much LGE?
more than 10% severe, ma'am.
Mhm.
More than 15% is very severe.
Mhm.
And LV apical aneurysm and apical fibrosis. You can better delineate with
See,
MRI. ma'am.
MRI is not a must in this case. What are the indications for MRI? We'll have to discuss that. See, when you have,
Suspicion.
not clear about the diagnosis, probably there it is required.
Yes, ma'am.
In this patient, I think there is no role for MRI. I mean, for everybody, it is recommended sort of, but ACCHA doesn't recommend.
Yes.
Only in unequivocal cases, there is, then when you want to decide on ICD to estimate the scar,
Scar.
but
Yes, ma'am.
not required for everybody actually.
Yes, ma'am.
he has clear indication for ICD. So
Yes.
we don't have to depend on MRI report, right?
Yes, ma'am.
Yes.
Okay.
Because there are 2 sudden deaths in the family.
Yes, ma'am.
So what is the surgical option, Sudarshan?
Surgical option, because of if he is willing for surgery, myomectomy,
Myectomy.
myectomy can be done.
Myoma,
What do
what
they
is
do in
myoma?
myectomy?
What is
Sorry.
myoma? Repeatedly you are
Myectomy
forgetting.
is-
What is myoma? Hmm?
Uterine
Okay.
myomas.
Yes, ma'am. Yes.
So myomectomy is myoma removal, not HCM surgery, right? That is
Yes, ma'am.
myectomy. Okay.
Myectomy. Yes.
Now, in this patient, resting gradient, you have seen it is not even 64,
Yes, ma'am.
isn't it? So,
Yes.
would you like to do something else to decide whether myectomy is going to make any difference to this patient?
So, provocative maneuvers like Valsalva and exercise test.
Anything else? He is lying in front of you for echocardiography.
The gradient is more than 50. Why do you want to do provocative test?
Yes.
It's quite a significant gradient,
Yes,
and
ma'am.
patient is highly symptomatic. Madam is asking about the other investigation, which will give you an idea of what's happening and
Yes,
what
ma'am.
other modality.
Post cardiac catheterization, post VPC, there's a potential.
Why do
Why
you
do you
want
want
to
to
do
do
that?
that? You have resting gradient itself is high.
Yes, ma'am. Yes.
Any other echo? Modality of echo?
Stress echo. Okay.
Stress echo, what is the need for stress echo? Trans esophageal echo you want to do?
T.
Do you need it in OT for them to identify and remove the myocardium?
Yes, ma'am.
Hmm?
Yes, ma'am.
Dr. Anupam, are you looking for that answer or something else?
I was just wondering that because the way echo is, it's not looking like very severe septal hypertrophy.
Correct.
So, in this case, would he still, or should we still send him, think of sending for myectomy? And septal reduction is going to help this patient. I think maybe MRI can also give information on that, but ICD definitely is indicated in this patient
Yes.
as early as possible. Then
Yes.
also, yeah, differential diagnosis has to be also clarified. It is amyloidosis or
Yeah.
what?
Yes.
So
But LVOT obstruction is one thing which is against amyloid. Otherwise, it looks like
yeah.
amyloid. Age and
Hmm.
it looks, yeah. How much myocardium will they remove, Sudarshan?
30%.
30%. What is this 30%?
From base to mid the septum.
You have to mention it in grams or
Yes, it is.
3 to 5 grams. They say size of a thumb.
Yes, ma'am.
3 to 5 grams. And transesophageal echo will guide them. If they over resect, then a patient can end up with VSR. Dr.
Yes.
Soumya, I think we are getting late. You want us to go ahead with the talk?
Ma'am, I think Dr. Sudarshan also might have been exhausted.
No. Yes, sir. Thank you.
If more PGs had attended and if the echo loops were running, it would have been more interesting discussion.
Correct. It would have been it. Correct.
Yeah.
But you did well, Dr. Sudarshan.
Thank you, ma'am.
Yeah.
Thank you.
Yeah. Hmm.
Presentation was very neat and yeah, good discussion. Yeah.
Thank you so much for this opportunity. So thank you, Dr. Soumya, for inviting me. So I won't take too long. It's a very elaborate topic on its own. but I just thought I'll highlight a few key concepts. I think you've done 80% of the madam has already discussed, and I think the presentation was also very good. So most of these concepts are discussed. I'll just probably be just emphasizing a few different ones. So it's important to understand that HCM, it is a genetic disease, but what we are understanding more and more is many patients can have the same genetic abnormality, but the final phenotype of the disease and the way it progresses, when it starts and how it evolves, it is different in each patient. And I think we'll all agree with that. So there is much more than just the genetic disease. There are primary effects, there are modifying effects, and that is finally how this disease manifests and progresses from a very asymptomatic patient to a very detrimental phenotype in some patients. So these are just 3 patients. All 3 of these patients were diagnosed with HCM. But what you need to understand is this is something similar to what was presented, someone with syncope and an LVOT obstruction, a typical HOCM. There are patients with maybe 20-25% of patients where there is non-obstructive HCM, and oftentimes they are very, very different than patients with an LVOT obstruction. Treatment is different, management is different, often clinical presentation in terms of their atrium dilatation, almost a restrictive pathology, they often present differently. And now more and more we are understanding that there are a group of diseases that mimic HCM, and it is our job to distinguish these from your sarcomeric HCM. The pure reason being that now there are disease-specific treatments that are available. So I'll just spend 10 minutes talking about contemporary management of obstructive hypertrophic cardiomyopathy, sudden death in HCM, and who needs an ICD, the newer evidence for metabolic modification, and why we do genetic testing. So I always like this slide because I saw that ECG with that SC elevation that he showed. There is anatomic LVH that we see in the echo, and there's electric LVH that we see in the ECG. Oftentimes, diseases like HCM have both anatomic and electrical LVH. This doesn't hold true in a few instances, especially patients with burnt out HCM, where they start developing LV dysfunction, where anatomical HCM, LVH will remain, but electrical LVH will regress. But if you ever see a mismatch between anatomic and electric LVH, especially someone with thick septum and low voltages, you should start thinking about systemic or infiltrative diseases like amyloid. Now, I won't go into this. I think we've discussed, Madam has discussed this echo a lot. But basic things that need to be looked for is, there is, like the patient that you're describing, if there is no obstruction, LVOT obstruction at rest, especially on the echocardiogram, it doesn't mean that this patient does not have HOCM. This is a very dynamic disease. It depends on the preload, afterload state, how much water they've taken, what drugs are they taking. So always try to look for this group of patients where there is no obstruction at rest, but obstruction does develop in a labile instance. This can be on a maneuver like a Valsalva or standing. This can be on leg raising, increasing the preload. This can be on giving certain medications also inside the cath lab. So these are the ways in which you can provoke a gradient. And this is very important because if you identify someone with a labile or an obstructive HCM, oftentimes the treatment is very different. Principle of management, I'm not going to get into. If there's anything that the PG should remember, number 1 drug to be given is beta blocker unless it's absolutely contraindicated. We've spoken about the newer drugs also. One drug I'd like to stress is that's probably still underutilized is disopyramide. It's cheap, readily available. Most patients tolerate the medication, and you just have to be sure of a few things when you give this drug. The general principle of LVOT HOCM management is you are creating a negative inotropic gradient, negative inotropic effect on the LV. Gradient comes down, and this is how we manage these patients with medicines. So disopyramide, I still feel, is grossly underutilized. It works very well in HOCM patients. The idea is negative inotropic agent that also increases the SVR. The only thing you need to watch for when you start this drug is QT prolongation, which occurs in maybe 5 to 10% of patients. If you give it to older patients, you need to watch out, especially for prostate issues, because there are some anticholinergic side effects. And always look for other drug interactions, especially in terms of class 3, giving it along with class 3 antiarrhythmics. You've mentioned mavacamten. I won't go into the trial disease. These are specific cardiac myosin inhibitors that are working for patients with sarcomeric HCM in order to reduce the LVOT obstruction. There are now newer generation molecules. The evidence looks promising. It is going to be expensive, but in our Indian patients, I still feel beta blocker and beta blocker plus disopyramide solves the HOCM in at least 75 to 80% of patients. In medically refractory situations like the ones that are listed here, symptoms, and when the patient is still symptomatic, patient has very poor exercise capacity, degree of MR is significant and associated with the obstruction. You do look at septal reduction therapy. Surgical myectomy remains the gold standard in terms of treatment. For patients who cannot tolerate a myectomy or do not want a myectomy, like Madam mentioned, alcohol septal ablation is a good option. I won't go into the details, but it is a treatment modality that is available. Like was also mentioned during the case presentation, other treatment modalities for septal reduction include radiofrequency ablation. That is quite effective if you are doing it in a localized area. The septal reduction is not much, but because of the dynamic interaction between the AML and the basal septum, ablation at that spot can often lead to some positive results. The second part is regarding SCD. Again, you see a patient here, 45-year-old male, HCM with syncope. Sometimes risk stratification is very easy. What do you see here? You see NSVT or VT runs on the baseline ECG itself. You don't need a Holter. Echo and cardiac MRI revealed a large apical aneurysm. If there's one thing to remember, patients with HCM and apical aneurysm have almost 5 to 6 times increased sudden cardiac death risk. So if you see anyone with an apical aneurysm, their SCD risk is higher. So this is a clear-cut indication for an ICD in these patients. Sometimes it's not easy. 50-year-old male, 1 episode of syncope, ECG Holter is normal. This is where the questions of doing a cardiac MRI, looking for late gadolinium enhancement, doing other provocative tests, and plus minus the role of an EP study is always done to risk stratify these kind of patients for sudden cardiac death. There are AHA and ESC have their different interpretations of sudden cardiac death risk stratification. These are the criteria that AHA uses: family histories, syncope, NSVT, LVH. The 3 newer criteria are an LV apical aneurysm, LG more than 15%, and EF that is less than 50%. The ESC risk calculator looks at more sort of numerical values again, but both of them basically tell you low or high risk for a ICD implantation. But one thing that you need to remember is each patient is different. So it's difficult to give a number to a patient and tell, like your patient had a very high family risk of SCD. So sometimes these numbers alone do not interplay, but you can use them as a guide. Third part is what about metabolic modifications? Not much for hypertrophic obstructive, but hypertrophic cardiomyopathy or non-obstructive cardiomyopathy is now being more and more understood as a metabolic disease. I won't go into it too much, but there are metabolic modifiers that are now being used to look at trying to change the metabolic profile of these patients with HCM. And one such treatment that we tried was SGLT2 inhibitors. So basically, they increase the ketone production or the ketone availability within the heart. And this has a positive effect in these kind of patients with hypertrophic cardiomyopathy. So this is also a lot of research that is going into metabolically modifying these patients with hypertrophic cardiomyopathy. Last 2 minutes, just to look at the HCM genetics and why genetic testing is useful. So you know that there are these sort of these 8, so-called 7 or 8 key genes that are involved in causing a sarcomeric HCM. But you need to understand, even if you do 100% genetic testing for patients with the HCM phenotype, oftentimes only 60% of patients will come back with a genetic mutation. So how do you explain these remaining 40%? One is we've not fully understood the genetic spectrum of HCM. And the other part we need to understand is, and these 2 examples will sort of understand. So what do you see here? 52-year-old male, significant LVH. You can see the QRS complexes are going off the ECG paper. You can see similar to your patient, there was a lot of STC segment depressions showing a high degree of left ventricular strain. Concentric left ventricular hypertrophy. And if this is not studied any further, we would say concentric LVH, HCM phenotype, and keep going. But you do need to look at a subset of these patients for HCM mimics. Here, the creatinine was high, urine protein was high, patient had a corneal and skin lesions, and there was a diagnosis based on genetic testing where this patient of Fabry's disease was made. So this is a very, why is this important to do is there is now treatable disease modifying drugs for Fabry's disease that are now available. And it also helps you in terms of genetic screening. This was the brother of this patient, asymptomatically screened, found to have severe LV dysfunction and found to have an apical thrombus with an apical aneurysm. So these are things that need to be thought about when you see someone where you are considering HCM now because treatment is available. Similarly, a very interesting 20-year-old girl, again, concentric, labeled as HCM. Madam asked you about this apical sparing pattern. So 20-year-old girl, apical sparing, our initial thing was apical sparing should be something like a possibly amyloidosis, but 20-year-old didn't make any sense to have amyloidosis. So storage, HCM, amyloid, or is it something else? This is where genetic testing was really helpful. This patient had a primary systemic carnitine deficiency. So again, this is a mimic of HCM. And here the very nice part is it is a carnitine deficiency. And the treatment that is available is orally supplementing carnitine. So again, similar to Fabry's, another treatable condition with a HCM mimic. And you can see how this patient improved following carnitine deficiency. And even these repolarization changes in the T waves changed after giving the patient carnitine. So again, genetic testing is useful for confirming sarcomeric mutation, but even more useful for patients in which you are suspecting that there is a HCM mimic and this disease may not be HCM as well. So last slide, HCM, you're talking about having imaging, clinical decision-making, interventional help, genetic interpretation of genetic testing in terms of pacing therapy. So the many people involved in the care of a HCM patients, but so these are things just to keep in mind. And I'll stop here. And if there's any questions, I'm happy to take any questions.
There are no questions in the chat box also.
No, very good presentation.
Thank
That last case, I am really wondering, like, are we missing out on this in some of our patients? Because, we are labeling everybody as HCM and genetic studies. Many of our patients are not able to afford.
So the clue there was the T wave. If there are peak T waves, madam, sometimes that it is a sign for this carnitine deficiency.
Sorry?
The peaked T waves in that ECG.
Peaked T waves.
So
Okay.
if you see very large, tall T waves in someone with a concentric LVH, those repolarization changes somehow are more common in these patients with a carnitine deficiency.
There is a question in the chat box. Sir, if hypertension patient with, I actually don't understand the question.
So I think they're asking if there's someone with that we've labeled as hypertensive heart disease, septum is 22 mm, should you undergo a genetic testing for HCM?
No history of non-obstructive.
So HCM diagnosis is not based on only on the septal thickness. So when you see an echo of a patient with HCM, there are other things you should look for other than just the septal thickness. You should look at the mitral valve. You should look at the papillary muscles. You should ask them to provoke a gradient and see what is there. And also nowadays, cardiac MRIs are very good in terms of understanding the phenotype a little bit better than echo. So I would do all of these things before just suggesting a genetic testing.
Generally, the thickness will not be around 20-22 in hypertension. It will not be this much thick. And some cases of overlap is also reported. Hypertension with HCM. That is also there. So we need to
CKD,
investigate further with MRI, as Dr. Muthaiya says.
Hypertension CKD, sometimes they get septums around 18, 19, 20.
Yes,
sometimes
yes.
it's there. So that's also something to check. Renovascular hypertension.
If there are no more questions, shall we conclude, ma'am?
Yeah, surely,
Right.
Soumya.
Thank you, Soumya.
Thank you,
Yeah.
Mutaya. Thank you, Nagmani ma'am. Thank you, Anupama ma'am, Jyotsna ma'am, and Dr. Anil sir. He was there all through the presentation. Hope more PGs would have attended, but we'll make sure next time that all the videos play.
Thanks,
Thank you, everyone.
Soumya.
Have a good night.
Thank you.
Good night.
Good night.
Thank you, ma'am. Thank you.